Good afternoon. My name is Wade Green, and this is my final project presentation for Dr. Welch's Qualitative Research course. This is entitled Concussion Symptomatology Experiences and Impact on Health-Related Quality of Life in Collegiate Student Athletes, a pilot qualitative investigation. Concussion assessment has been taught to athletic trainers over time by the Concussion and Sport Group's recommendations. That is essentially where we as athletic trainers have learned concussion management. Graded symptom scales, neuropsychological testing, and balance assessment have been regarded as cornerstones of management, and those are things that all of us use day to day in our own clinical practice. We're going to focus a little bit on symptom report scales. Symptom report scales are varied. There are many of them that are out there, but they typically involve a list of 22 to 45 items rated on a Likert type scale, of 0 being a score of no symptoms per item to 6 of severe symptoms on that item. This is the most common method of reporting and tracking symptoms in our patient population, and really in sports medicine as a whole. There have been efforts to decrease the amount of variation and increase the validity of these instruments. And one such statistical analysis that's been used to accomplish that is called the RASH analysis. Gardesian and colleagues examined the post-concussion symptom questionnaire to reported patient symptoms and assessed it for fit. They were able to whittle down the post-concussion symptom questionnaire from 45 questions to 19 questions, which really indicated redundancy or really too much variation to assess a symptom properly. Another issue that we see with symptom report scales is that Garden and colleagues examined base rates of concussion symptoms in non-concussed university students. One of their main findings was that post-concussion symptoms are reported in 37 to 81% of non-concussed people. And so really a very wide range there of concussion symptomatology experience in non-concussed controls. When we get into self-reported symptoms and health-related quality of life, there was a study by Vassiliadis, McCartney, Berriman, Anderson, and Dube that examined the self-report symptoms of a pediatric population and also health-related quality of life via the PEDS QL. And what they found was that 62% of the variance in scores on the PEDS QL in this population was caused by trouble sleeping and memory problems. They also noted that females displayed consistently lower scores on health-related quality of life domains when compared to males with concussion symptoms. Another aspect of graded symptom checklists and self-report symptom scales is that sometimes what is expressed on those scales can be influenced by either by informational literature and information given to patients. Waldron, Perrine et al. Discovered that participants that received documentation regarding their concussion recovery that was perceived as positive usually reported fewer symptoms 6 months post-injury than those who received literature that stated that they may experience either a prolonged recovery or those that didn't receive any literature at all. Kemp, Sullivan, and Edmed compared the usage of the term mild traumatic brain injury with concussion in hospital discharge instructions to examine the effect of that language on symptom experience and reporting in patients. And their hypothesis that mild traumatic brain injury would lead to greater symptoms and worse patient outcomes was not supported. They did not find a difference between the mild traumatic brain injury group and the concussion group, if you will. There are other factors that have been reported as interpersonal factors that influence symptom experience. Kerr et al. In a 2014 study reported that athletes still struggle to identify their respective symptoms with concussion due to a number of potential factors, being lack of education and others. To date, there has been one qualitative study that I came across in my preparation for this project by Adavia, Roiger, and Zwart. And they conducted a qualitative investigation into health-related quality of life of adolescents at 1 year post-concussion. And four major themes were derived from that investigation. One of those was the significant effect of relationships, feelings of frustration, influence on school attendance and activities, and lastly, the nature of interpersonal and team relationships. The one thing that the symptom report, the self-report symptom scales lack is that of the patient perspective. It is true that we are measuring that perspective, but we are not obtaining rich data from a first-person qualitative perspective, and we don't necessarily know how the patient perceives those symptoms. So, as mentioned before, there's been one study to date that's examined health-related quality of life, but no one at this point has really kind of taken a look at symptom experience. So this current study sought to investigate concussion symptom experience and its impact on health-related quality of life via a semi-structured interview process. And the research question that has been proposed for this investigation is, how are concussion symptoms experienced among collegiate athletes, and how do they impact the construct of health-related quality of life? So, 3 college-age student athletes with a history of concussion were selected to participate in this study. 3 face-to-face semi-structured interviews were conducted with the participants. Participants chose pseudonyms to protect their identity and HIPAA information. Interviews were recorded in order for the researcher to familiarize himself with the data to be transcribed, and in addition, all participants provided written consent for their interviews to be recorded. We chose a maximum variation sampling method for this study for a few reasons. We wanted to really capture a holistic perspective on symptom experience in this investigation. Since this was a pilot study with few participants, we selected this sampling technique, maximum variation sampling, to hopefully maximize the richness of our data. In addition, 2 non-concussed males that had sustained a concussion in the past 18 months were included, as well as 1 female currently experiencing concussion symptoms. So, in review, 3 participants with a mean age of 19.7, with a standard deviation of 1.25 years old, in age at the time of the study, and there was an average of 4 plus or minus 1.41 concussions sustained per athlete. The qualitative tradition that was selected for this study was the phenomenological tradition, because the researcher is attempting to study a phenomenon and is lived out and experienced. We didn't attempt to assume or connect symptomatology to health-related quality of life in a cause and effect manner, so we ruled out a grounded theory approach to analysis. This study was chiefly concerned with exploring symptom experiences and health-related quality of life experiences within the construct of sport-related concussion. Interviews were transcribed by hand by the primary investigator. Transcription was verbatim except to avoid HIPAA-protected information, truncate unnecessary pauses or fragments. Member checks were utilized to ensure trustworthiness of data, and data were coded in meaning units assigned as adapted from Saldana in his book, with assistance from our textbook by Pitney and Parker. So we derived 5 major themes from our data analysis in this study. Those were flawed symptom conceptualization, cognitive effect of symptom impact, social relational deficits, memory considerations, and present and future health-related quality of life concerns. There were 2 additional content areas that were not coded into themes. They were academic symptom impact and biomechanical influences. These areas were omitted from the coding process because, although they were provided in the interviews, they departed from the true meaning of the study. They really got more into the concussion management aspect of how we care for concussions, as well as the uh, as well as symptom reporting behavior, which kind of veered off track of what the purpose was for our investigation. So the first theme identified, flawed symptom conceptualization. There were two main codes that really kind of were pivotal in developing this theme. Those were generic symptom experience and symptom expectation fallacy. And so, in order to explain that, we'll kind of get into some of our raw data here from our transcription. Doug, one of our participants, tells us, you know that you have one, a concussion, when you start feeling dizzy and have all the symptoms. Joe, our female participant, elaborates, I have all the symptoms. I definitely know it's a concussion now, but at the beginning it was just memory loss. I thought I was just having little brain problems, but I definitely didn't know it was a concussion. And then Joe also elaborates, I had the same typical concussion symptoms, headache, sensitivity to light and noise, balance problems, just the typical, the basic ones. So there's an overarching concept here that there is some sort of criteria of symptom encompassment that defines concussion to our patients. That it's not as we perceive it. We perceive concussion to be any number of these symptoms, but there appears to be some sort of symptom expectation that defines what a concussion is and is not. The next theme that we came across was cognitive effect of symptom impact. This was very, very interesting. There were three main codes that influenced the generation of this theme, and those were increased symptom anticipation, symptom-centric paranoia, and negative self-concept and depression. So Doug again starts off for us, and he tells us that I would say that since I've had concussions, or more concussions, I've kind of been on edge about a lot of things. And Doug gives us a little bit of insight into his own anxiety and potentially even paranoia about the occurrence of symptoms. And he says, just because I always think, well, do I have one? I always think that. Not just because I'm so on edge about it. I'm just like, do I have one? And then I start thinking. And then I actually overwhelm myself into that. And then Doug continues in referencing student athletes and potentially even teammates that have had concussion and his assumed fear that they'll experience. He tells us if they've had one, they're always going to have it in the back of their mind. They're always going to have it in the back of their mind of, that fear of getting one. And then referring again to his own anxiety and fear in regards to concussion, specifically in reference to future problems down the road. He says it really does ring a scary bell to me, which shows that he is really kind of concerned and worried about the long-term effects. Jo elaborates for us. She says, in speaking of how her second concussion occurred, it was weird during the game, and I would just tell her every time that I felt something, and that repetition was added for emphasis, and that was something that was a part of our data. Jo seemed to really hint at there a heightened sense of awareness with each experienced symptom. In addition, she spoke to the psychosocial side of things. She said, I'm more emotional and like nervous a lot for nothing. Like I'm going to class, I'm nervous, I'm going to get a headache. I'm just kind of scared to do normal things that a normal person wouldn't be nervous about, like going to class. And then she alludes to some depression. Jo says, and I can tell when I'm definitely more depressed. You get depressed more easily, but you stay depressed longer also. Like, you don't get over things as fast. Our third theme that emerged was social relational deficits. And two main codes that really were brought out and then were used to create this theme was decreased social threshold and then voluntary isolation. So what we mean by decreased social threshold is not only a decreased desire for social interaction, but increased irritability with social interaction as well. And then also we're going to see through voluntary isolation those that may make a voluntary choice to remove themselves from social situations. Doug tells us, oh, during a concussion, I'm very to myself. I really don't converse with anyone. And in speaking of her symptoms and how it affects her socially, Joe says, yes, it does affect me. For one, I'm very irritable, and I can tell because I have a 2-year-old. So I can just kind of tell the difference of how fast she can irritate me, rather than like how she can normally irritate me. And our third participant, Adam, in speaking of how it affects him and his social relationships, tells us, no, I wouldn't say. I mean, I can still want to interact and still do. It's just maybe not as lengthy. I guess maybe sometimes you can avoid it if you just don't feel like doing anything. Another salient theme that we identified was present and future health-related quality of life concerns. And the two codes that emerged for us here were fear of long-term consequences and fear avoidance of symptoms. And Doug tells us through his own symptom experience, after elaborating on having symptoms of a concussion, he says, you know, you're experiencing the symptoms and you're just wondering if you're going to be okay later in your life. And Doug also elaborated on a fear of his when he said, when I'm older and in my golden years, so to speak, I don't want that, being concussion symptoms, to affect me. And Joe hints at present difficulties with health-related quality of life. She says, you know, to try to you know, go play or go run or just walking. If I walk for a long time, that's too much for me at this point. This one's a lot worse than the first two. Physical activity like bending over and putting on your shoes and then coming back up, that's horrible. Or picking up my baby, that's horrible. Stuff like that. Just easy stuff that shouldn't be a problem is a problem. And then Joe also says, in regards to future concerns about health-related quality of life, she says, it makes you think about your future life. I mean, is this always going to happen? Am I always going to get concussed so easily? Am I going to be back to normal one day? Am I going to get my memory back? Anybody would think that. And Adam elaborates. His interview was actually one of the more brief interviews that was conducted, but he did tell us this about his concerns about health-related quality of life. He said, if you mess up your head, then that can mess up your life down the road. That was how he voiced his future concerns, and especially those in regards to concussion symptoms. In addition, Adam said that right now, presently, when asked if it affects him from a physical, if the symptoms affect his physical well-being, he said, yeah, I would say so. You know, I mean, obviously, if you're having concussions or you've had them, it can take a toll on your body and your mind and stuff like that. So yeah, I would say it has a big impact on the way that I perceive my health. And then finally, the last construct, or the last theme that we identified, was memory considerations. There were two primary codes that contributed to this theme, and those were significant memory impact and then concussion memory disconnect. So Joe gives us a window into her own memory problems, and this can even be kind of extrapolated a bit further to talk about cognitive symptoms. So Joe says this one, being this concussion, the third one, feels very much like everything's wrong in my brain, like concentration problems, drowsiness, not being able to focus my eyes. That's the worst part, not being able to focus my eyes. And then Joe comments again. And then with my third one, all that memory loss, I knew that wasn't normal at all. And that, you know, once again harkens back to the symptom expectation fallacy in the generic symptom experience, that there are certain symptoms that are automatically associated with concussion, while others aren't necessarily as present for some. Adam elaborates on his own difficulties with memory. He says, I think my memory might be a little hazy sometimes, like I don't remember simple things. And he also comments. I have a hard time concentrating sometimes on schoolwork and stuff. I don't know if that has anything to do with it either, but I guess it could. So, once again, Adam gives us some insight there into memory considerations, but he also tells us that he's not necessarily sure if his memory deficits are related to his concussion. And Jo also hints at that when she says that earlier that memory problems didn't necessarily equal concussion for her. So there's definitely a disconnect between memory problems and between perceived concussion in these patients. So, wrapping up, this study sought to investigate the experiences of collegiate student athletes with concussion symptomatology and their impact on health-related quality of life. 5 major themes were identified: flawed symptom conceptualization, cognitive effect of symptom impact, social relational deficits, current and future health-related quality of life concerns, and memory considerations. These findings support previous work which relates a lack of knowledge about concussive symptoms, specifically by Kerr et al. In 2014. A novel finding in this investigation is that of the fear associated with concussion symptoms and its impact on daily life for college students, as well as some of the psychosocial concerns. Our study captures additional themes related to health-related quality of life that agree with other studies, such as diminished health-related quality of life, as well as continued problems with symptoms and social interaction. And then additionally, while formal measurement of this construct through the use of PROS was not done, I do think that this further substantiates the findings of reduced health-related quality of life in patients with sports-related concussion from a first-person perspective. There were some limitations to this study. Due to time constraints, field observations were not conducted, potentially limiting the richness of the data obtained in this study. The small sample size made data saturation more difficult to achieve. And then, due to our sampling method, we interviewed 2 patients without current concussive symptoms and 1 with current protracted symptoms. The lack of consistency in those patient characteristics may have affected our data and may also make reproducibility difficult. In conclusion, concussion symptoms can have a significant effect on health-related quality of life in physical, psychological, and social domains. There's a salient psychosocial effect, and student athletes may experience significant anxiety or paranoia about the occurrence or recurrence of symptoms with a suspected concussion. Many of the student athletes interviewed here have verbalized concerns about their health and well-being in the future. Further qualitative investigation should be conducted with larger sample sizes to identify patient-centered concerns with concussion symptoms and management. And here are the references for this presentation. And I want to thank everyone for watching this presentation, and congratulate you on the completion of fall block 2, and wish you a very restful and holiday season. Thank you.